Good morning to one and all present here. Devapratim Das could not come due to some emergency, so I will be presenting. Being co-author, I will be presenting the case. To begin with, cataract surgery in a patient with Down syndrome, a surgical challenge. To begin with, pediatric cataract accounts for 5 to 20% of blindness worldwide. Children with Down syndrome have an increased risk of being born with cataract or developing cataract later in life. The frequency of early cataract in Down syndrome requiring surgery during childhood is rare, but timely removal and rehabilitation is of utmost importance. So this was a case of an 11-year-old male child presented with diminution of vision of both the eyes, right more than left, for last 2 years, which was gradual in onset and progressive in nature. Patient was mentally retarded, there was developmental delay, and then associated cardiac abnormalities were present. Positive family history was present, and mother was elderly. Antenatal and postnatal history was not significant. Personal history, sleep, snoring was present, daytime sleepiness was there, appetite, bladder, and bowel habits were normal. So on examination, systemic examination, CNS examination of CNS examination shows low IQ and cognitive impairment, whereas in CVS examination, VSD, AR, atrial enlargement was seen. Ocular examination shows visual acuity of 6/60 and lamellar cataract. Along with that, the rest of the findings were normal. On routine examination, blood investigations were normal, whereas in chest X-ray, right hilar haziness is marked, right descending pulmonary artery is markedly enlarged. ECG was normal, whereas echo shows VSD, ventricular septal defect, atrial regurgitation, atrial enlargement. USG-B scan shows cataractous lens, and the biometry shows plus 21.50 diopter of both the eye. Now, a diagnosis of developmental cataract, both eye with Down syndrome with cardiovascular abnormalities, was made. Now, initially we planned for phacoemulsification right eye with foldable IOL implantation under general anesthesia. But the surgical challenges which comes in Down syndrome patient are like patient is very much anxious or agitated. There are communication difficulties, hemodynamic instability in cardiac valve problems, atlantoaxial instability or atlanto-occipital instability is present. Obstructive sleep apnea might be there, and aspiration during sedation might be present. So in my patient, communication difficulties were there because patient was mentally retarded, cardiac valve problems were present, and obstructive sleep apnea was also there. So after discussing all the pros and cons and informing patients attendant about the high risk involved in general anesthesia, it was decided to operate the patient under local anesthesia. Proper patients and attendant counseling was done, and phacoemulsification right eye with foldable IOL implantation under local anesthesia was planned, followed by visual rehabilitation. Now, this patient, if we operate under local anesthesia, also the risk was patient was we cannot communicate with patient properly because he was mentally retarded and he was having low IQ level. So we have to take the mother inside the OT to counsel the patient and to sit there during the OT. So post-operative follow-up was done. The patient was doing fine. Wound site was healthy, clear cornea, minimal AC reaction. Lens was in position. Best corrected visual acuity was 6/12. Follow-up was done after 15 days, and BCVA was found to be 6/9, and there was N6 for near correction. So, surgical, medical, and developmental outcomes in patients with Down syndrome and cataract who have cataract requiring surgery experience high surgical complication rates. But in our case, there was no surgical complication because after 9 months of follow-up also, there was no such complication seen. Down syndrome and early cataract, the frequency of early cataract among children with Down syndrome is estimated to be 1.4%, with cataract requiring surgery during childhood being even rarer. So in our case, cataract was there and it needed surgery. Also, the outcomes of cataract surgery in children with Down syndrome has been, there are other associated complications like strabismus or nystagmus might be there. In this case, there was no such complication. Whereas primary posterior capsular access with and without anterior vitrectomy in congenital cataract is needed in patient younger than 5 years with congenital cataract. Also in younger patient, we do continuous capsular access and intravitrectomy to prevent posterior capsular opacification. But in this case, we did not do that. But there was no such complication after 9 months of follow-up, and 2 months back also, the patient's other eye was also operated similarly. Acrylic lenses was used, which according to study also delay the development of PCO. So to conclude with, the early detection and timely surgical intervention gives a good visual recovery. High risk associated with general anesthesia in patients of Down syndrome must be taken into consideration. In our case, high risk was there. Patient could not be taken for general anesthesia, and also with local anesthesia also we have risk, because if we cannot counsel the patient because patient was mentally retarded, but we have to operate the patient because patient with so much of comorbidities and associated mental retardation, if diminution of vision can affect the quality of life. So we have to operate the patient. Proper counseling and a good meticulous surgery in experienced hand prevents post-operative complication. Thank you.
So was there any surgical challenge during the surgery?
Sir?
Was there any surgical challenge, as you said? It's a cataract.
So surgical challenges, we thought of surgical challenges because patient during the surgery, patient might get up and we cannot do anything.
Counter any?
Because patient's mother was there inside the OT, she was allowed to sit there, and like that we have operated the case.
No. What I am saying, during surgery, did you face any difficulties?
No.
Speaking, your case went off quite smoothly.
Yes,
you
sir.
didn't face any challenge.
Initially, anesthesia people were asked, but they sought high risk consent because of so much of comorbidities, and also patient party was not very willing to give the consent. So we thought of operating under local anesthesia, and we have to operate the patient because it was gradually progressive only. And with the quality of life, if patient is seeing less and also the other comorbidities, we have to operate. So in Down syndrome patient, this is a challenge.
So patient cooperation is the only thing that you face, and the problem. Otherwise, surgery as such is not very difficult.
Surgery as such is not. Thank you, sir.
Sedation was also not given to the patient.
No, sir. No, ma'am.
Very commendable job. Very commendable job in
Thank you,
this
ma'am.
case to discuss. That was my first question, whether any sedation was used during the surgery, because otherwise a child, it tends to get uncooperative during surgery. So even giving the block, did you all face any difficulties at that time?
No, low block we could give.
Okay.
Block we could give, and then sedation was not done.
Okay. And the other eye, are you planning?
Done. 2 months back it was done. This was done around 9 months back. There was no posterior capsular opacification, which we were like thinking that there might be PCO, but it was
I didn't catch which lens you used.
acrylic hydrophobic lens. Acrylic hydrophobic foldable lens. Thank you.